We'll begin with the session. So just to introduce our program director, Dr. Viraj Lavingia. He is director, Oncosciences, Shalby Hospital, Ahmedabad. We have Dr. Chirag Desai sir and Dr. Shailesh Talati sir as our chairpersons. Dr. Chirag Desai sir, if you can quickly come and introduce our speaker, Dr. Milind Javle sir.
So good evening, everyone, and thank you very much for being here. Thank you very much, Surveyor, for giving the opportunity of interacting with Professor Javle for a lovely discussion on upper GI cancers. We know that mainly two cancers in upper GI arena, biliary tract cancer and pancreatic cancer. For past maybe 2-3 decades, we hardly had any new things on hand. We were discussing a lot about the new development and translating into the improved outcome of the patient. We hardly had anything. Whatever was being hyped at was offering the survival advantage of around 2 months, 3 months, or something like that. And now we have a new molecular targets, new drugs to improve the outcome for this drug. So for these two cancers, we can say that the past was tense. The present is not perfect, but the future looks bright. And to take us to the pathway of that brightness for the future, I invite Dr. Milind Javle to give his talk. Dr. Milind Javle doesn't need any introduction to this audience. He frequents India for multiple interactions in the medical conferences. He is a professor of GI medical oncology at the prestigious MD Anderson Cancer Center. I could go on to introduce him for a long time, but that will come between us and the academic discussion with Professor Javle. So, Dr. Javle, please.
Thank you, sir.
Thank you so much for your very kind introduction. I feel like I'm with friends, and it's great to be here. I'm going to talk about a very focused area, second line options in biliary tract cancer. This is an area that I've been working on for really, like, I want to say 15 years. And it's exciting because in the past nobody was interested. We couldn't do anything other than fall fox. And there's so much that has happened, and I'm very proud to be on that journey with all of you. First, some introduction. We used to call biliary tract cancers, classify them anatomically, right, with intrahepatic, extrahepatic, gallbladder. But that is still valuable, especially for us surgeons. For us, really what matters is how you can treat them in the advanced disease stage. So I think we are going more to a definition of small duct and large duct, because the mutational profile and treatment approach for small duct, where you have IDH1, FGFR, varies from large duct, where you're more likely KRAS, TP53, CDKN2A, etc. So we are going more into a molecular classification, and it has implications much more than anatomical. So we have this rising incidence of cholangiocarcinoma. This is our analysis of SEER database. I think important thing to say is, like, some of these people are diagnosed cancer unknown primary, this green line. Those patients do worse. So if the patients are fortunate enough to see an experienced group of people like you, then you will diagnose that. But otherwise people get, Taxol and all kinds of treatments for unknown primary and delays their treatment. Now there's a big relationship between, we think, body BMI. This is MD Anderson, where we are a kind of a big BMI state in Texas, whereas Princess Margaret in Toronto, much lower. We have the highest liver cancer mortality rate in the US. And actually, I'm really worried about us as a population in India and also in China, because we have an epidemic of type 2 diabetes. And we see that with type 2 diabetes, there's a very high risk of steatosis in the liver. So we believe that actually it's JAMA article recently, 2040, liver cancer, which is HCC and cholangio, will be among the top 5 causes of cancer death just because of liver-related, steatosis-related complications. Now, a fellow of mine looked at what are the real world patterns. We think of like median survival of a year and a half, all that. This is practices around Texas. So 85% of patients get first line. If you look around the world, it's only 60%. 40% don't get any treatment. They're too advanced. 46% get second line and 17% get third line. And if you look at real world data, actually median duration of treatment is about 3-4 months. It's not necessarily 8 months and 10 months. So it's an area of great unmet need. I'll just have one slide about chemotherapy because Gemcis was a standard for 10 years. This study, Gemcis Abraxane, was developed at Anderson by my junior colleague, Dr. Shroff. She did a phase 3 trial, 450 patients. Unfortunately, no improvement in the survival with addition of chemotherapy, third line. So there's some thought that gallbladder cancer might have a better outcome, but it was not statistically powered. In parallel to this, there was a trial of FOLFIRINOX in France, which showed no benefit against Gemcis. So multi-agent chemotherapy has not been valuable. The most recent signal has come with immunotherapy. And I admit it's a modest signal. The Topaz-1 trial where patients got Gemcis and Durva versus Gemcis and placebo in the first line setting. This trial also enrolled in the US, and there was a modest improvement in survival from 11.5 to 12.8 months. But really what matters to us is at 2 years, 25% of patients were well as with durvalumab compared to 10% with those who got placebo in the maintenance setting. So this trial also showed us that you can actually stop chemo after 6 months, give the immunotherapy alone, and have a good quality of life. Similar data from Keynote 966. Well, as you know, this was Gemcis and pembrolizumab, and in the maintenance setting, it was Gem plus Pembro. So it's chemo as well in the maintenance setting. So we are learning in our practice now how to incorporate that. There's a group of patients, perhaps you will continue some chemo, not discontinue at 6 months, and we learn, to estimate risk. Well, unfortunately, majority of patients in advanced disease recur, and in terms of the non-targeted options, we just have FOLFOX with a PFS of 4 months, OS of 6 months from the ABC06 trial, so not a particularly great standard. And then from Korea, and then later on in the US, the liposomal irinotecan 5-FU, which had a OS of 8 months versus 5 months with 5-FU alone. So these are the two standards, which are not really wonderful standards for second-line chemotherapy with FOLFOX or FOLFIRI or NALIRI. What has really changed in this in the last, I want to say 6 years, is the advent of novel agents based on molecular profiling. So you have a variety of FGFR inhibitors. I think FGFR is not approved, right, in India? Do you get the bit? Not yet. And ivosidenib is now approved in India. And then you have BRAF, HER2 inhibitors, and then more recently you have several agents that even if they're not approved, some of them are in the guidelines. So this has become very exciting because it's like a non-small cell lung cancer, and pharma, fortunately, is looking at us as an avenue for accelerated drug approval. So we would never have these talks 10 years ago. Nobody was interested. But now we have an exciting trajectory. And these are our data like over 10 years ago now. We started profiling intrahepatic, extrahepatic gallbladder, which showed that there's a large number of patients with iCCA who have actionable mutations, and we'll discuss some of them in the near future. We thought KRAS is not actionable, but isn't it exciting? Now we finally have KRAS drugs and daraxonrasib, etc. They really work, although they are toxic. So the challenge in delivering precision medicine is, of course, having a good quality molecular profiling. You have hyalocholangio. I just saw a patient within the last hour. You cannot get enough tissue. Liquid biopsy is required. But for most patients with intrahepatic cholangio, we should be able to get NGS. And when the original sample is not adequate, I do make it a point to see if we can get a repeat biopsy. In the community, sometimes not enough tissue. And the major challenge in biliary cancer otherwise is Cytology is not enough. Failed tissue samples because there's a lot of necrotic tissue. But without that, we really don't offer patients a lot with just chemotherapy alone. What about ctDNA? I see that in India, I saw patients, you use it frequently. I think the advantage is that the ease of sampling, and I think the biggest advantage in my view is serial sampling. So I try to get serial sampling every time the patient progresses on therapy. And now we are actually incorporating things like MRD testing in the advanced disease setting to measure the tumor burden, where you see stable disease for a long time, you really don't know where it's headed. So it's still experimental. I won't recommend it for everybody, but certainly and you folks, you think outside the box, and I'm happy to see that. So I'm going to spend the next few minutes talking about IDH1 and ivosidenib. So you're all familiar with the Krebs cycle from medical school, where you have in the IDH1 is involved in generation of alpha-ketoglucarate from isocitrate, and isocitrate dehydrogenase 1 or 2 are the enzyme involved. And when you have a mutation in the enzyme, you have 2HG. 2HG is mutagenic, and that leads to oncogenesis by altered epigenetic regulation, DNA methylation, and DNA damage. So you have treated leukemia, AML, right, with IDH1 mutation. In leukemia, the leukemic cells or the cancer cells are exquisitely sensitive to high 2HG level. So that's why you get with ivosidenib, you get 40-50% response rate with leukemia. Well, solid tumors, we have a more difficult story. There are many other mutations. So some of the cells are dependent on 2HG, but not all of them. So one of my fellows looked at the spectrum of IDH1 mutations from the AACR and publicly available database. So about 20%. There was a paper recently from Moshami and then Sevanti Limay, and I think the incidence is probably lower in India, but we don't know. I mean, we haven't sequenced enough people to know for sure. But it's about 15 to 20% in the West, and a lot of the data from India actually parallels that versus as compared to East Asia. So we'll have to generate data, you'll have to generate some data in a population, but they all occur in the arginine 132 domain and substituted with an amino acid like leucine or others, where you have 5 or 6 different types of mutations, all in R132, which are, we don't know if any one has more significance than the other in terms of predictive value. IDH2 are much less frequent, more seen in glioma, and they occur in arginine 172 domain. Now, we know that IDH2 inhibitors work, but they're different from your classical TKI, where you inhibit the ATP binding, and this really is a metabolic inhibitor. So it blocks the mutant IDH enzyme and production of 2HG, and then secondary to that, it restores methylation and normal differentiation. So it's a very indirect way, not our classical way, and perhaps that also impacts on the response rate and so on. So the first trial was the Clarity 3 trial. I mean, I have patients on this trial, from this trial, that I'm still have in my practice. So it was about 120 patients who had GEMCIS first line, and they had IDH1 mutation, advanced disease, were randomized to ivosidenib versus placebo and crossover. So there was 2-to-1 randomization. So there were 180 patients, 120 in the ivosidenib and 60 in the placebo arm. All general similar criteria. Almost all of them had in ICCA or intrahepatic cholangiocarcinoma. Now, as you can imagine, if you have a crossover design, it's hard to tell what is the survival difference. So the survival improved from 7 months to 10 months. So this was not statistically significant, 0.09. But when they did statistical modeling to take the noise away from crossover, this rank preservation structural failure time method, actually it was 5 months versus 10 months. So that was a significant improvement. There was an improvement in PFS, but very marginal, right? 1.4 to 2.7 months. But what you notice when you use this drug is 25% of the patients have disease control for 1 year. And these patients have disease control with very good quality of life. And that's really what got the drug the approval, not that, less than 2 months improvement in PFS. Some of the side effects are listed here. There's nausea, diarrhea, fatigue. I always counsel my referring physicians, do monitor the EKG every month or a couple of months, because you do get the occasional QTC prolongation and VTAC. But interestingly, more people discontinued placebo arm for toxicity than ivosidenib. In fact, when you treat patients, I find sometimes even when they're progressing, they don't want to stop the drug because they feel good. So, of course, it has side effects, but really nothing compared to what we see in our practice with other agents. This has been confirmed in a real-world study where you had a median follow-up of 13 months. Again, the overall survival was a PFS 4.4, OS of 15 months, so similar. Now, I'm asked, actually, one of the younger patients, smart fellow I met just now, asked me, what is the mechanism of resistance? Well, we did this liquid biopsy before and after. And again, this is not for people who don't respond, but people who do well for a year or so. And then you do liquid biopsy and or tumor biopsy. There's a phenomenon we think of isoform switching, where R132 becomes R172. And this patient actually developed a PI3 kinase mutation. So maybe there's merit in going after this, we don't know. But I think by collecting these data, and I think with India, our biggest wealth is the patients we see, the number of patients we see. So I think serial blood collections, tumor biopsy collections, I think will provide a lot of yield, and we can learn a lot from our patients in that way. Now, where are we going with this drug? Well, there was a phase 1 study, one of our fellows, actually friend, he published recently with Gemsys with ivosidenib. This is the Lilly drug. We don't know if it's more effective, but it's certainly tolerable. And then one of our fellows, Shalini, looked at immune profile in cholangio. And this is the immune profile of IDH mutation, and this is one with wild type. So you look at NK cells, macrophages, PD-1. It's an extremely immunosuppressed tumor. So you would think, like, what is the point of giving immunotherapy then? Because actually there's good preclinical data that if you suppress the IDH2-HG with ivosidenib, the tumor becomes more immunogenic. That is the preclinical data. So that is the rationale why this is being combined with Gemsys and Durva and Gemsys and Pembro in the first-line setting with chemotherapy. I do believe, you may see incremental effects when you combine it because these are so immunosuppressed. So there's a first-line ongoing trial in the US with Gemsys and Durva, and their patients are allowed one cycle till you get the NGS back, and if the IDH1 is positive, you add ivosidenib at that time. So there's an ongoing trial, the ABC-10 in Europe, where patients get Gemsys and Durva, and in the maintenance phase, they get either ivosidenib, FGFR, BRAF, or some of these agents in the maintenance setting. So that's so much about IDH1. I'm going to go into FGFR, and after that into HER2, which are these are just two pathways that I'll discuss after this one. And FGFR signaling, this pathway, our group has been working for over 10 years. FGFR, the characteristic abnormality that you see is FGFR fusion. And this was reported by Arul Chinayan's group in University of Michigan in 2013. And then, we looked at what is the clinical phenotype. So this is my fellow Apurva. She looked at 90 patients around the country. She reported that these patients are younger. They're more likely Caucasian than East Asian, more women. And they, interestingly, have a better prognosis. FGFR fusion patients do better. They live longer. So you can consider more aggressive local therapies. And then this will lead to our first trial. This was actually began as an IST and then became a national trial of infigratinib, which is given for patients with previously treated chemotherapy and FGFR gene fusion or rearrangement. So I'm going to spend 1 minute on this. You will often see FGFR gene fusion, where you have the FGFR2 gene fused to any of like up to 140 or 150 different partners. Or you can see a rearrangement where you don't know who the partner is, what is this gene. So they're no difference, same implication. These patients were treated with infigratinib. It had a 25% response rate, PFS of 6 months. The drug got FDA approved. There are two more drugs now. Currently, there are only two drugs approved in the US, pemigatinib and furibatinib. 35% response rate with pemigatinib, and PFS of about 8 months. And then furibatinib, which is 40% response rate, PFS of 9 months. The most recent one is lirafrugratinib. In the phase 1 study, the actual response rate was close to 80%, but at JISCO they presented it's more like 50%, but the duration of response is 1 year. So these drugs really work. But they stopped working at some point. So we did serial blood biopsies again to see what is the mechanism of resistance. And we see different mutations come up in the blood, again in the FGFR2 gene. Gatekeeper mutations, molecular brake, others. These are all the mutations that you see. And they don't respond to pemigatinib, infigratinib, or furibatinib, not even to relay 4008, lirafrugratinib. So we are working on a molecule, tinengotinib, which is an interesting molecule because it binds in a scaffold away from the ATP binding site. So the ATP binding site, these different mutations come up. This is actually binding at a different site. And with a much stronger affinity, as you can see, high affinities there. And then this was investigated in the second line space for patients who had received prior FGFR inhibitor. These were the data presented at ESMO, where for all comers, people who got prior FGFR or not, a PFS of 7 and OS of 16 months. But for those who had received prior FGFR inhibitors, like pemigatinib or furibatinib, it still worked. 6 months PFS and OS of 17 months. So we think like this is a scenario where you look, you use Gemcis durva, then you use, say, pemigatinib, furibatinib, and then if that becomes resistant, you do a liquid biopsy, and then treat the patient with tinengotinib. Hopefully we'll get there. This is an ongoing phase 3 trial. We'll be finishing it probably by this summer, and we'll see what the signal shows. So the last portion, I'll talk about HER2. This is, of course, a gene you know well. You treat in various different cancers, in GI, breast, etc. This was one of our first studies done with Chile, a pathologist in Chile, showed about 13% are HER2 positive. Now the 3+. Now in India, I believe the recent papers we had, it's almost 20%. I don't know if it's what you see in your practice, but seems like a higher number here, which is very interesting to see, more in gallbladder cancer. And this was our first study with trastuzumab, pertuzumab, 23% response rate, but deep responses for as long as 8 months. And my colleague Shubham presented data with zanidatamab, which showed, majority of patients, 70% have response. Duration of response is almost like a year with zanidatamab. Zanidatamab targets the trastuzumab binding domain and the pertuzumab binding domain, bispecific antibody. Enhertu, a drug that you use often, right? The antibody drug conjugate with HER2 3+, 56%. So another thing we are noticing is that there's not a strong concordance in biliary between HER2 amplification and IHC 3+. I've had patients who referred to me who say, well, this we gave HER2, it was high degree of amplification, didn't respond. And when you actually did IHC, it was lower. These IHC criteria were developed for breast cancer, stomach cancer. We don't really have IHC criteria. So I think we need IHC of 3+ really to respond, or 2+ with FISH. So this is the ongoing Destiny BTC1 trial, phase 3, where patients with HER2 3+ get either randomized to Gemcis or Durva, or they get Enhertu or Enhertu plus Rivastomig, which is a bispecific targeting PD-L1 and TIGIT antibody, and hopefully we will see a signal there in the first line setting. So we have come a long way. And what is the next? I think the next immediate future is novel antibody drug conjugates. So we have Enhertu, TROP2 is very high in BTC. Chlorine less so, 15-20%. One of my fellows, Nakul Shah, did publishing a paper with FGFR2b, which might be positive CDH6. I don't know that CAR-T has any future in this cancer because we have safer and easier option. The low-hanging fruit is MTAP loss, right, which with PRMT5 inhibitors, which occurs in actually 20% of population. So I think this is the next exciting area that we'll hear about, HER2 mutation, and whoever thought we will have KRAS targeting drugs in our lifetime. Now there are several. most of them, I want to say, are coming from China. We need to develop them in India, but these drugs work. So this is such an exciting area for precision medicine in biliary tract cancer, and I'm very hopeful for what lies ahead. I like to end with a little aphorism or saying, as when you reach the end of what you should know, you will be at the beginning of what you should sense. So we are at a new journey in biliary tract cancer, which was an orphan amongst orphans, and will teach us a lot about management, not just of this cancer, but management of many other cancers through its course. So thank you again. I am really honored to be here and participate in this meeting with you. People online? Yeah.
If any questions.
Yes. Oh, wonderful. Who is, what company is this, Viraj? Which company? Okay, Lupin. Right.
So, for cholangio, we have not touched cholangio cohort. What partner drug are we using? What data
Right.
do we have? Because
So
PRMT
there's-
mono doesn't do well.
No. So actually, I want to just highlight for those who don't deal with MTAP loss every day. It is an alteration which we commonly see almost 60-70% of the time when you have a CDKN2A deletion. So CDKN2A gene can be mutated or completely deleted. When it's completely deleted, then MTAP loss is very common, which is in the purine pathway, and PRMT has like a synthetic lethal interaction with that. So it is a stabilizing type of drug, Viraj. We had a paper which showed, just like I was in there, it's highly immune suppressed, and when you give it, when you inhibit it, then you have more of an immune reaction. So our feeling right now is immunotherapy is the best partner. And so it's being investigated a lot in lung, where nobody has shown much interest in us in biliary, but I think this is something you can pioneer here.
So, just off the record, one patient on 1B program is doing very well in colorectal space.
Wonderful.
But along with regorafenib, and regorafenib was already failed in past.
Right.
So
Right.
we're still learning what could be the partner with.
Right. So I mean, there are trials in pancreas with chemotherapy, with gemabraxine,
First line.
first line.
And you
And-
have to have MTAP or all comers?
No, MTAP loss.
MTAP.
I mean, I think it's very high, right? CDK in pancreas, 50, 60, pretty high number, but they have to have that. We have a phase 1 with PRMT5, I think the BMS drug, along with nivolumab, just because it's BMS. And, but that's sort of where we think we're going. But it's a stabilizing drug. Yeah, I've had some patients who had long stable disease.
Thank you, sir. Oh, do we have questions from any other centers? We have Bangalore and Kolkata. Can we unmute Bangalore? Unmute the Bangalore team.
Yeah. Good evening, sir. I'm Dr. Vishwanath.
Oh, yes. Hello. How are you, Vishwanath?
I have a question about this co-mutations.
Co-mutation?
Co-mutations. If patient
Co-mutation.
has FGFR with IDH or say HER2 with IDH, what is your experience?
So, I think we are learning a lot, Vishwanath, about co-mutation and response. The one that I'm most familiar with is with FGFR, just because we worked on for so long. And FGFR and IDH don't occur commonly at all. It's very rare. But it does occur with TP53, CDKN2AB. When you have those, they don't do that well. So actually those 50, 20, 30% that have no benefit with FGFR inhibitors often have those types of tumor suppressor mutations. With IDH1, there is some, actually I was at ASCO GI, there was some data to show that ARID1A co-mutation with IDH1 may have a predictive value where, as you know, IDH1 is thought to have a DNA repair damage type of pathway and ARID1 too. So the thought is that when they're together, they have a better outcome with ivosidenib. Um, so in terms of HER2 and IDH1, I've never seen them together. But when I do see occasionally something like that, like say the very rare patient we have FGFR2 fusion and IDH1 mutation, I will go for FGFR2 fusion just because it's a more active, right, drug pathway. So HER2, the same thing. I mean, you have if you have HER2 and KRAS, of course, it's never going to work. But if you have HER2 amplification and IH3 plus, I mean, the zanidatamab and HER2 work just so well. You will just go more often. But we are going to see a pathway, Vishwanath, aren't we, where we are going to put this into AI and Claude and you know, that will give us the right answer.
Thank you, sir. Also, you mentioned about this PH mutation. It causes a very immunosuppressive microenvironment.
Right.
Trial where you add IDH1 blockers and so that this trial going on. But in your experience, have you done that? Where patient has got an IDH1 mutation, have you added immunotherapy?
Yes. So I've done it, and actually, anecdotally, Vishwanath, I think these people do better because even when they have received, say, durvalumab before, I do believe there is some merit in IDH1 inhibition and immune reactivation because it's just so immunosuppressed. It's amazing. Like you have hardly but it's not like it's a T cell depletion. It's a T cell exhaustion environment. So you can reactivate the exhaustion with by inhibiting the IDH1. That's what we feel. Good to see you. Thank you for joining me all the way from Bangalore.
Milind, hi, Dr. Mangesh here.
Yeah.
So thank you for the extensive presentation of what is also coming up in the space. I just want to ask you a question. We do not have too much data of combining immunotherapy with HER2 targeted therapy in the cholangiocarcinoma space, but we have a lot of Indian data that's coming and also Indian experience coming. That if you were to combine HER2 targeted therapy with immunotherapy, we are actually getting very good results. What's your take on this?
I agree with you, Mangesh. So in the Topaz 1 trial, they actually felt that, the forest plot was going the wrong way toward GemCis when compared GemCis and placebo as compared with GemCis and durvalumab with the HER2. So they felt maybe, but it was just not powered. Like gastric cancer. Certainly, you know how it goes there with trastuzumab and pembrolizumab. We don't know, but I think we will love to find out. So this sort of thing you can find out with a very small study. Like 5 patients, get pre-treatment biopsy, post-treatment biopsy, look for simple markers like PDL1 status before and after, look at TMB sequencing. You can have proof to concept. And there's an ongoing trial now. Both Zani and HER2 first line trials are including immunotherapy. Yeah.
I have another question. So when you're treating these patients, for example, you have a patient, you have probably detected a mutation, maybe an FGFR or IDH1 when you started on therapy. There's not much data, but the data is upcoming with regards to maintenance. So in current scenario, when you don't have actual data for giving IDH1 targeted or FGFR targeted maintenance, What do we do when we have exhausted, say, durvalumab with chemotherapy, and then we just want to continue on durvalumab? Do you continue to recommend that we employ maintenance with any of these target therapies, or do you still say, let's just continue durvalumab and wait for progression and then go for the target therapy? What do you recommend right now?
Right. So, Mangesh, we don't know, do we? I mean, the Saphir trial from from Europe is basically asking what you're suggesting. Can you use targeted therapy along with immunotherapy in the maintenance setting? I certainly think drugs like, say, PARP inhibitor in pancreas, right? Similar, we have a paper like that in coming in biliary, or even ivosidenib. It would make sense to continue them in the maintenance setting. What I do in my own practice is, before stopping the Gemsys and going to Durva maintenance, we think of like what is the individual risk. If the patient has peritoneal disease, if the patient has impending portal vein biliary obstruction or something, I'm hesitant to stop the chemo, to be honest with you, because I feel like, you see some people where the disease progresses when you stop, and those people have such a low margin for failure that I continue it or even jump single agent. But patients who have like a few lung or liver mets, I think it's safe. I mean, you have to stop it and you can always go back to chemo later. So it's more about whether you continue chemo in the maintenance phase or not. As far as targeted therapy, I've used ivosidenib plus durva in the maintenance phase, but it's certainly outside the box.
Hello, Dr. Javle. This is Dr. Supreet from Bangalore.
Yes.
My question is pertaining to the third line systemic therapy options, because once in a while we do come across some of the patients doing well, even when they have progression on second line. And there we are always tempted to offer something. And we know that if they have some targeted therapy option feasible, that can be attempted. But if there are no targetable genetic alterations, that is when the question of third line therapy arises. There is some data of nivo lenvatinib that I was going through. There is some data for bev erlotinib. Are these options really good, or is there anything else that we can offer? There is also some data of lenva combination with first line treatment itself. So can we do all these in actual practice yet?
Yeah, I mean, I think it's a loaded question, Supreet. We, in the approved regimens in the third line setting for us in NCCN, besides, Folfox, Folfiri, are regorafenib. I think I don't know what I find my Indian patients tolerate regorafenib extremely poorly. So I use very low doses, right? Like Lenvima and Pembro, like the LEAP trial. So we use that. But in that case, we use really low doses, like 8 milligrams or even lower than that, sometimes 6, just because 12 is too hard, or certainly 20 is extremely hard to tolerate. And then if you have, I think you mentioned erlotinib, we don't, unless it's an EGFR amplification, not really. So we have some TKI options. None of them are particularly wonderful, but I think we can. I mean, if the patient is in good physical condition. And you'll be surprised how few patients actually receive liver-directed therapy. So even when patients have metastatic disease or disease that has progressed, not necessarily confined to the liver, if they have a mass-forming liver lesion and they have a few oligometastatic lesions, the patient is more likely going to die from liver failure from the progressive hepatic mass. So I think there's merit to considering something like that, SBRT, sometimes Y90 for patients who you think are going to die from liver mortality.
Any other questions from Kolkata team or any other from Bangalore team? Any questions from?
I'm asking the question slightly different, because now you see the role of Naliri in pancreatic cancer coming up, and traditionally we all understood that pancreatic cancer has a microenvironment that is very resistant for the chemotherapy to enter, and that is the reason why Abraxane came into pancreatic cancer, and now we have Naliri coming up in pancreatic cancer. Now, as much as it has done, we are seeing that Naliri is being tried outside pancreatic cancer in later lines in GB cancer as well as also in colorectal cancer. So, how do you look at the role of Naliri outside pancreatic cancer when you don't have that, the applicability of that resistant microenvironment as compared to the pancreatic cancer? Do you think that's working differently, or you think that probably an irinotecan would work the same way in gallbladder or colorectal cancer?
Yeah, I think so. You touched upon earlier that both these tumors have a fibrotic microenvironment, right? More than pancreas, more than the than cholangio, but that too because of steatosis, they have fibrosis. But in terms of Naliri, all we have currently are the data that I showed, right? Which from Korea and then here. If I have to use an IV chemotherapy regimen after gemcitabine durva, actually I prefer Naliri versus FOLFOX. I mean, yes, you have the ABC6 trial, but they just had cisplatin. You have neuropathy, things like that. And there are interesting areas you will find when you do molecular profiling, ATM mutations, which occur like, single digit numbers, DNA repair mutations and alterations. They really respond well to irinotecan. So there are situations where I think is exceptionally beneficial, but most of the time it has, marginal benefit. It's a little better than FOLFOX.
Thank you.
Hello. Yeah, hi sir. I'm Dr. Rajiv from Calcutta. So I have a couple of questions. First of all, thank you for that wonderful presentation. So both my questions pertain to first line setting. So sometimes we come across patients who have a poor performance status where we cannot give the gemcitabine with cisplatin. We have to
Right.
just contain with a gemcitabine or at most an S1 or a capecitabine along with that. So in that situation, if we find out a good mutation like FGFR2 or IDH, what do you reckon? Should we start off with chemotherapy in the first line setting and reserve the targeted agents for the later lines, or should we go upfront? What is your take on that?
Yeah, I mean, you're right. There are some patients where the window has not closed, but it's open just a crack. So you don't have a lot of great options. Patients with FGFR fusions, it is rare to find them untreatable because it's generally, they're in good physical condition. But if I mean, 20% of the patients in our practice not in our practice in the US, never get any treatment at all because they're just too sick. So then we will use the pancreatic paradigm like single agent GEM or GEM plus durva, perhaps an ECOG performance status of 2. I certainly think what you said makes sense. In that case, we should try to use targeted therapies upfront, as a single agent or in combination with GEM if it's applicable. For instance, trastuzumab certainly, ivosidenib FGFR single agent. I think it's worth considering in those patients. Yeah.
So my second question would be that we now have two first-line immunotherapy indication, one with durvalumab alone maintenance, along with another one with pembrolizumab, and in combination with gemcitabine maintenance. So, which do you have any favorites between these two, or it's just can be used interchangeably?
I think they're superimposable. Durvalumab had the first approval, and honestly, we were so comfortable with it, and there was no reason we found to switch. And then the data for maintenance therapy is with single agent durva, isn't it? With no chemo. Patients love that, and but I don't think there's a difference, honestly. I think it's superimposable and depends on your level of comfort. I believe Pembro is cheaper, right, in India than durva. Yeah.
Thank you. Thank you.
Talati, thank you so much. We'll begin the next sessions.
All right. Thank you very much.
Thank you so much, Dr. Javle, sir, for your first of all, giving the presentation and then answering the questions by our team. Next up, we have the diagnostic session, that is diagnostic dilemmas in biliary tract cancer by Dr. Ekta Jajodia. She is a consultant molecular pathologist in Unipath Labs here in Ahmedabad. Over to you, ma'am.
Hello, good evening, everyone. So I shall be taking about the diagnostic dilemma that we have during the biliary tract cancers. And the first slide says that when and how should we test? So the molecular profiling is recommended in advanced disease, considered for systemic therapy. Okay, and since there are a lot of genes that has to be tested for biliary tract cancers, it is important that we do parallel sequencing by focused NGS and not single gene testing. Even if you're interested in a single gene like IDH1 to consider for the IDH1 inhibitors, it is very important that we do focused NGS to look at a set of multiple genes. Now, before any non-surgical treatment, a core biopsy should be taken for diagnostic pathology and molecular profiling. So at diagnostic sample can be taken even if you're not doing the molecular diagnosis at diagnosis. Then also the sample to be used is preferably the one which was taken for diagnosis for histopathology. So NGS can be done on the FFP sample, but it is sometimes very difficult to get enough tissue. And as sir has already told, sometimes we need to do repeat biopsy to get adequate amount of tissue. And if repeat biopsy is not really possible, then we can also do on the liquid biopsy. So the minimum amount of RNA or the DNA required to do a NGS is typically around 20 to 50 nanograms. So anything if the tumor cellularity is low, or sometimes what happens is tumor cellularity is good enough on the block, but because of the fixation issues can happen during the histopathology diagnosis, and that fixation issues can lead to low quality DNA extraction. So all this either the tumor cellularity is low, or because of the fixation the DNA quantity is not adequate. So in either case it is very possible that we can take a liquid biopsy and get the molecular testing done. So in the liquid biopsy, we usually test for the circulating cell-free DNA that has come from the tumor. So circulating tumor DNA as well as cell-free DNA, whichever is the lab doing, so it can be done on that sample. The pre-analytical issues that happen in the molecular testing is the thing which I have told you, that NGS sometimes fail when DNA is extracted from old FFP samples or from the FFP samples which are not properly fixed. So the DNA quality or the quantity may be hampered in such cases. And the second is the tissue age, tissue ischemia time, temperature, fixation time, storage conditions. All these can affect the FFP DNA extraction. So in all these cases, we can consider the role of liquid biopsy. In the liquid biopsy, the ctDNAs are small fragments of DNA which are between 90 to 150 base pairs. The amount of ctDNA varies depending upon the tumor burden, the location, the metastasis, and the treatment already received by the patient. And the advantages of liquid biopsy is it is a very heterogeneous population of cell-free DNA comes into the in the plasma, and so when we take a biopsy, we may take only from one part of the tumor, but liquid biopsy, the cell-free DNA will come from all the parts of the tumor. So a heterogeneous tumor population can be molecularly characterized. And ctDNA can be done for early detection of the disease, screening of the patients at risk of developing cancer, then to identify therapeutic targets, and also during the response of the treatment to assess whether the patient is really responding or is resistant to the treatment. Now, to look at the actionable mutations, as sir has already told, we have to first divide the biliary tract cancers into the anatomically based on intrahepatic or the extrahepatic cancers. And most of the mutations that we usually are interested in is seen in the intrahepatic cancers. Although extrahepatic cholangiocarcinoma also has a lot of mutations like KRAS and SMAD4TP53, but intrahepatic cholangiocarcinomas has the IDH1 and 2 mutations, the IRID1A, the BAP1, the FGFR fusions. So all these come in the intrahepatic. In the intrahepatic cancers, IDH1-2, as already asked by Dr. Vishwanath from Bangalore, he said that whether co-mutations are seen or not. So IDH1 and 2 are mutually exclusive with FGFR fusions, and the most common mutations that can happen with IDH1 and 2 are usually TP53 or rarely it could be IRID1A. So these are the rare mutations that can happen with IDH1 and 2. And classification of CCA is still anatomical, but in the future, we do not know in future the classification may be molecularly based, because a lot of some types of cancer in the cholangiocarcinoma behaves or resembles more like pancreatobiliary cancers. So based on the mutations, classification may soon be seen. And the ESMO guidelines in 2025, they have said that the biliary tract cancers can be early stage, locally advanced, or advanced or metastatic. So in the locally advanced stage is the subset of patients where we need to do the molecular profiling. When the chemotherapy has failed and now the patient is locally advanced, in such cases we can look at the molecular profiling, and based on the different mutations, targeted therapies are available. So especially the important mutations or the fusions that has to be looked into are the IDH1 mutation, because we have targeted therapy for that. Then we can look at FGFR2 fusions, BRAF mutation, MSI status, whether it is high, unstable or stable, HER2 overexpression, NTRK fusions, RET fusions, and BRCA1-2 or PALB2. So these are the different fusions and mutations that are important in biliary tract cancers. So wherever possible, NGS testing should be performed early, preferably at first diagnosis, and initiation of first-line systemic therapy or advanced disease. So that if the first-line systemic therapy fails, the second-line treatment targeting the identified actionable genomic alterations can be initiated without delay. So if the finances is not a problem, then at diagnosis, the molecular profiling should be done for all cases of biliary tract cancers. Again, based on the ESMO guidelines, the most important mutations and fusions to be looked into are IDH1, FGFR2 fusions and mutations both. BRAF, as the V600E is the hotspot mutation. NTRK is always fusion, so it has multiple fusion partners. NTRK has to be looked only for fusions. And HER2 amplification. HER2 amplification can be looked into by IHC method or the FISH. And microsatellite instability again can be done by IHC or molecular testing, whichever is suitable. In IDH1 and 2, it is seen in around 15 to 20% of the intrahepatic cholangiocarcinoma. IDH1 is more common, IDH2 is very rare. And in the IDH1, we usually look at the hotspot mutation at the 132, protein number 132, where usually arginine is present. The most common mutation is replacement of arginine by cysteine. And there are multiple other replacements, could be serine, could be histidine. So there are many other, but the cysteine, arginine to cysteine is the most common. In IDH2, which is a very rarer mutation, we look at codon 172, which is the most common hotspot mutation in IDH2. So again, as sir has told, I'll briefly tell you, IDH1 is important in the Krebs cycle. So when mutations happen, the IDH1, instead of converting into the alpha ketoglutarate, it gets converted to hydroxyglutarate, and 2-hydroxyglutarate is oncogenic, and so it promotes DNA damage and a lot of promotes carcinogenesis. So accumulation of 2-hydroxyglutarate is actually the main cause of the promotion of the cancer here. So for the molecular techniques, NGS testing should be performed early, preferably at the first diagnosis of cholangiocarcinoma. Both RNA and DNA should be extracted because all the mutations can be screened with the DNA, and for all the fusions, RNA is required. So both should be extracted from the same biopsy sample. And RNA sequencing is recommended to detect novel gene fusions, to look at the gene expressions and alternative splicing. And there are NGS testing, approved CDX NGS test that can give you the targeted treatments as per the mutation identified. So there are multiple, when we report the NGS report, we usually report in 5 subsets, whether it is pathogenic, likely pathogenic, VUS, likely benign or benign. So usually likely benign and benign mutations are not reported in the NGS report. Pathogenic and likely pathogenic are definitely causative for the disease, and VUS is a variant of uncertain significance, is again debatable whether it is going to affect the patient's disease condition or not, or whether we should target the gene with the targeted therapy or not. So that is again debatable. So a trial can be taken if you find a VUS, whether you should give you may or may not give the targeted therapy against that particular mutation. So to conclude, molecular profiling using NGS is very vital for accurate diagnosis and clinical decision making, and it can be used in for early molecular profiling in patients diagnosed with advanced or metastatic cholangiocarcinoma. Further development of NGS techniques requires very less tumor tissue can also give you a definitive diagnosis, is still under process, and liquid biopsy can always be considered as an alternative testing option, because in liquid biopsy only with a peripheral sample you can take both, you can diagnose both fusions as well as mutations, but a validated test is required. So a validated test in a validated lab is the must for such cases. Thank you.
Any questions?
Thank you.
Thank you so much, ma'am. We'll begin with case discussion moderated by Dr. Viraj Lavingia, sir.
So thank you, Sarvier. We were supposed to have 3 cases discussed by 3 different oncologists, but I think so in the view of time, in the next 20 minutes we'll discuss all 3 cases, and I'll just drive the real case scenarios and we'll take each one of yours opinion. So this is the case 1. We have in the audience medical oncologists, surgeons, and we have a molecular pathologist. We have a hepatologist from the same institute that I am. Manas, would you want to come in front? Right. In fact, so Javle sir, just the MDT that we have here, the city of Ahmedabad, which you praised about, the MDT is even much better in the multi-speciality hospitals. So the benefit of having multi-speciality hospitals. So yesterday night, one of my young patient taking immunotherapy presented with fulminant hepatic failure, SGPT of 20,000, and that was viral hepatitis, and that got just screwed by immunotherapy. So thanks to our hepatology colleagues rescuing the medical oncology team. So okay, so I was just digressing, but this patient is a 55 female, good performance status, and as you can see on the imaging, there's a lesion. Where is it? There's a lesion in the gallbladder, and There are no separate liver metastasis, but as you can see, there's a different section that it is also infiltrating the liver surface. So, you know, this is a common scenario. We have a subhepatic mass. We see this it's not uncommon in Gujarat to have a subhepatic mass. So question to our surgical colleagues, and as a medical oncology we always ask, biopsy or we just go in and take it out? So as a surgeon, sir, Hitesh Chawda sir is our fantastic liver surgeon here in the city of Ahmedabad for last 20 years. So sir, how do, and we have a lot of students, DNB in the backside, so guide us, how do we decide that which one we poke or which one we leave it to you to take it out?
I mean, this seems to be a locally advanced disease, so of course biopsy first.
Locally advanced, we biopsy.
Yeah. So
what are the criteria? So because it's a liver infiltration, that's why?
Well, this can be resected, but probably this patient will need some neoadjuvant treatment followed by surgery. So in that context, I would suggest, I mean, if this is the only disease, it can be resected.
Right,
but
this is the only disease.
Seems to have a big mass, so probably he will recur. So biopsy, neoadjuvant, and then resection. That's what I would say.
So in gallbladder cancer, is neoadjuvant therapy really what we practice generally? Because still the guidelines say unresectable, go to medical oncology, resectable, operation. This development of mixed treatment where medical oncology does 2 or 3 months and then surgeon, when do you, in your last 20 years, when do you think we have evolved like this?
I mean, I don't see so many gallbladders still. We see more cholangio than gallbladder.
Right.
But still I would suggest that, because we have seen such patients where the recurrence is there. So to improve the result, we would give something to downstage the disease, and then
right,
probably operate to see the behavior also.
So Bhavin sir works in the same hospital, initially used to. So sir, what would be that something if a surgeon were to ask us that, what do you think, let's say we biopsy, it's adenocarcinoma, what would you think, how would you move forward with this?
So if it is inoperable, it is in our side, and then we have to treat it with the chemotherapy. Now 56-year female with good performance status, no comorbidities, so we should give the whatever the base is possible, that gemcitabine and cisplatin based treatment can be planned. And because it is inoperable, I think we should assign the NGS panel. If we can get some molecularly targeted therapy, then we can consider for at that time or in future if necessary.
Right. So sir, just on that point, he said he can resect later on. So this is a very gray zone, right? He's not saying this is never coming to me. So in this situation, what kind of systemic therapy we should choose? Because he wants response rates. Gemcis is what, 20-25%. So in your practice, what do you want to add something, get more shrinkage so that he can operate this better? Do we do MDTs like that?
The other options we have like FOLFIRI or FOLFOX like protocol we can use that may help in such patients. So I think that is the base we can offer to the patient.
Right. Hi Archit, if I can get you in. So if this were to come in your hospital, what kind of systemic therapy options you're looking to help our surgical colleagues here? Like, do you want to intensify, or still ABC Gemcis is your go-to?
So usually we offer Gemcis plus immunotherapy based therapy. We do NGS. Usually we don't act upon at the first line. And I have seen in my practice this patient hardly respond with neoadjuvant. Majority of them we continue the same treatment without doing surgeries.
Okay.
At later point of time.
Pinaki, what
I
about
think, what I think you are alluding to is to use a triple drug therapy like FOLFIRINOX.
or Abraxane.
Yeah. So we do discuss, but I think, as Archit said, most of the times we would use GEMSIS. That is something that we are comfortable in the first line. But that option, yes, we should discuss, because when we have a young patient who is otherwise fit, why not to use a more aggressive, maybe get a higher response. As I said, most of the patients actually don't respond very well and go on to go for a surgery. The extent of the surgery essentially remains the same even if you give chemotherapy.
So, Javle sir, yes, yes, Chirag sir.
Yeah. So, in the real life situation, many times it so happens. I will give the situation first and then I will pass on the mic to you. That in the MDT, the surgeon says shrink the tumor and then I will operate. Right? Sometimes I'm looking at not particularly this scan, but sometimes at looking at the scan, I say that really, are you going to operate? After I give 2, 3, 4, 5, 6 cycles of chemotherapy, are you going to operate? Sometimes it so happens that we give 3 cycles of chemotherapy, get the new scan, and there is some shrinkage of the tumor, not amounting to partial response. I mean, that happens many a times. And then the surgeon says that give 2 more cycles, shrink the tumor a little more, and we keep on giving the chemotherapy, and then the tumor starts growing again, and then now it's not operable. So I mean, how do you objectively decide that when to give neoadjuvant therapy?
Gallbladder.
Whether this is actually a neoadjuvant therapy, right? I mean, with the central lesion there, etc. But I agree with all that said. I mean, I would also do like HER2 testing with, but the trials generally allow up to 3 months. And the neoadjuvant trials that we have had were for intrahepatic cholangio. And we found that although you're right, the response rate was 25%, not really high, even if they don't have a response, you identify a good trajectory of the cancer, that they're not progressing. And like many other immunotherapy neoadjuvant trials, patients have a better survival even without a high PAT-CR rate and a high response rate, because we believe that preoperatively it's a better perfused tumor, it's more immunogenic, and non-metastatic disease. So I think it makes sense to treat. I wouldn't build their hope up about surgery very much because, but I think about 3 months is what we made.
And so just circling back on that, Dr. Shroff did a triplet gap regimen. With gap, do you think responses are going towards 35, 40%?
Actually, that trial, Viraj,
especially
we did see a high response rate, like 45%.
Especially in the gallbladders.
Including in gallbladder.
Including in the gallbladders.
And, like you saw in that phase 3 trial, the survival was better in gallbladder than others.
Right.
I think we'll have to learn from you because you treat a lot more.
We have more gallbladders in India than... True.
Perhaps it's something.
True. Hitesh sir, coming back to you, staging laparoscopy, yes, no? In gallbladder cancer, in biliary tract cancer?
I mean, yes, we do staging laparoscopy.
Before sending to the medical oncologist or at the time you are going in?
I mean, what sometimes we do is we do try to see an aortocaval node. If it is positive.
In the staging lab?
No, in EUS. If there is it's very difficult to see in a PET CT as well.
Correct.
See, if you see the right side image,
right.
there is a node. Yeah, so that node, if it is positive, it becomes M1 already.
So how do you see that?
So you have to do a EUS and take a biopsy, FNSC, and then see.
EUS, so Manas, how do we reach there?
So aortocaval lymph nodes can be biopsied with the EUS.
From the top or the bottom?
Top.
From the top?
Yeah.
Okay. No, please educate us. So how far you have to go in?
So aortocaval lymph node can be biopsied at the level of esophagus or maybe from the first station of the stomach. So we can get a biopsy done and if possible FNAB with the 22 gauge needle, and then the biopsy is positive, then the decision would be much easier. When the biopsy is negative, then issue will be there, whether to consider this a truly metastatic or just
So
inflammatory
in
lymph.
Tata Memorial, they have developed this protocol of doing staging lab before handing over to the medical oncology colleagues, like truly making sure that if at all they respond well, you will operate. So wanted to just ask on that. Um, Alurkar sir, uh, do we have any experience of using neoadjuvant radiotherapy in this? Because if you see SGPGI and Chandigarh, they all add CTRT. AIMS Delhi adds CTRT. Tata Memorial has done the Polka study adding CTRT in the neoadjuvant setting to help our surgeons. What are your thoughts on that?
So as far as the Polka is concerned, it's a one-off study. So there are a lot of flaws in that study. I would not really use it as a recommendation in routine practice for a CTRT. I would still go ahead, because if you consider this case, I would still go ahead only with chemotherapy.
Just chemotherapy. So where would you want to use RT? In cholangio?
Not really sure.
Not sure. Sir, Chirag sir, Talati sir, have you used RT in cholangio in practice?
No.
No.
And the question, as a follow-up question to surgeon is that will you touch the patient if patient has undergone radiation? You will. You don't find surgery difficult, healing difficult after radiation to the gallbladder or hepatic base or something like that?
Siddharth.
Okay.
So, Dr. Siddharth is here from HCG. Dr. Siddharth, any experience? I know Samir does GI radiation oncology. When I was in HCG, we used to do neoadjuvant radiation. Do you have any experience? Rina engineer, yeah. Oh. Okay. Okay. Okay, so Hitesh sir, this was real study from the Polka gallbladder study, where it was sandwiched chemo, Gemsys, CTRT, and then 2 more doses of chemo, and later on this patient had a complete response. So here, as a surgeon, what would you say? Go in, or whatever you're doing, continue?
No, of course go in.
Of course go in.
Go and resect.
Resect.
Yeah. As a protocol, we do laparoscopy or open surgery,
Right.
do aortocaval node frozen, and then resect if it is negative.
Right.
Radical cholecystectomy.
Open radical cystectomy. So in this case, patient did underwent open radical cholecystectomy, and fortunately for this lady, it was a PAT CR. There was no disease. Since we did only 4 months, Bhavin sir, would you want to do any maintenance here, or want to do MRD, or what are your thoughts, or just observation?
I think just observation.
Just observation. Anybody in the house want to do an MRD here, or just observation, or some maintenance? No?
If MRD turns out positive, what will
Exactly.
you do?
So that was my question to Javle sir, because sir, at this case, if MRD we do Signetra, and Signetra is available in India, and it pops positive. How would you deal? Because I know in MD Anderson you guys do Signetra for BTC.
Yeah, I mean, first of all, great choice on therapy, and I'm glad she did so well. We don't do it. I think it may be a learning curve for surgery or something, but I've just grown up in an era where you don't give this heavy radiation to the liver before surgery. But we would monitor with Signature. The more difficult question is, Viraj, what do you do with that information?
Right.
So in colon, we have trials now.
Yes.
That will hopefully come to us down the road. But yes, we are right now in the phase of gathering data, gathering evidence.
So you don't act upon it, you just do surveillance.
Right now we don't act on it.
Okay.
colon, if the ctDNA is positive, you just observe that patient, or do you
We
offer?
have a trial.
Yeah.
We have a trial. For
They have a
them.
trial. Dr. Kopet's
Early intervention versus
Yeah.
wait for radiology. So there's an ongoing trial.
Okay.
Yeah.
National trial.
Because when trial is not possible, we have one patient who has a young patient fit. Now we have sent ctDNA after adjuvant chemotherapy for colon cancer, right-sided colon. Turned out ctDNA is positive. Now whether to treat it, because we don't have any trial.
Yeah.
So that is a dilemma.
So yeah, for BTC, I have a discussion with the patient that we are going to measure it, and we may not know what to do with it. And if you're uncomfortable, let's not do it. And some people don't do it for that reason. But you know, usually you do find serial values. If you get PET scan or something, you know, something shows up. Yeah. Right. Yes. Mm-hmm. We do it every time we do a restate. Unless radiologically we don't treat. I mean, I'm trying to get enough data so we can do a trial. But right now we don't treat.
Right. Thank you, sir. Let's move on to another case scenario. And again, this is a scenario which we encounter frequently. Large liver mass, 14 centimeters, with signs of portal hypertension, splenomegaly, ascites, something going on in the omentum mesenteric fat, we don't know what is it, and there is a small extrahepatic lymph node outside the liver, and these are the liver markers. We have cirrhosis, the mass looks very much like HCC, AFP is elevated, PIVCA is not so much, CA19-9, CA are normal. So Manas, let me come back to you. What are the criteria of doing a biopsy in a liver SOL where our radiologist says this is HCC, there is a background cirrhosis? How do you decide in your practice? AFP is elevated.
So first criteria, again you told this is cirrhotic. So in non-cirrhotic HCC, number 1. Number 2, HVOTO, if the etiology is HVOTO. Number 3, when we are suspecting mixed phenotypic tumor.
So when
like
do you suspect?
cholangio. So if atypical characterization on the MR or CA99 is also elevated along with the alpha fetoprotein or PIVCA2.
So only PET CT is enough for you to go, or you still want to do an MR?
MR. For characterization of the HCC, the CT or MR is the main thing rather than a PET CT.
Okay, right. Alurkar sir, PET scan, this is the report, patient is coming with AFP elevated, cirrhosis. Would we, and Dubal sir is saying HCC, will we go ahead with HCC or you want to poke? Biopsy. 100% biopsy. So, Hitesh sir, what about you in your practice?
I mean, patient had directly PET CT or some imaging?
There was an ultrasound.
Oh.
There was an ultrasound large SOL.
I will do biopsy. MR also and biopsy, because this seems anyway inoperable.
Correct.
So, we have to give something. So, biopsy is must.
So, we have students sir, so tell me, in an inoperable metastatic disease, when one should not do a biopsy?
In inoperable metastatic disease.
This matters, there is a lymph node outside.
Hmm.
When we should not do biopsy?
See,
we should take it as HCC.
If the PIVCA or AFP is elevated.
AFP is elevated.
No, this is not significant.
75 is not
No,
significant.
no, it's not significant. So if it is more than 400,
400.
maybe 900 or 1000, 1500, then we assume that it is HCC. We have burned our finger in the past,
Correct.
assuming that this is HCC, but
Right.
we have seen even transplanted
Correct.
patient having
Correct.
mix or pure
True.
cholangio, you know.
True,
So this is 75 is not significant. So
Correct.
Biopsy is
So we had 5000 AFP coming as pure cholangio. So we were all.
So
I
yeah,
agree.
so always if you're offering a curative option, even that case also we always do biopsy.
So Viraj,
Sir,
I just
I
want to make
always
a
feel-
point for the, especially for the younger fellows, is we do a lot of PET CT in India. I'm not sure why. Everybody gets a lot of PET CT, but the HCC has a very characteristic CT finding, right?
Right.
With early enhancement, rapid portal washout.
Right.
That's almost as good as an AFP of 400, I would always biopsy. But I think it's important to also, I mean, imaging is of great value.
Right. Right, I do hear that.
And the cholangio and others have delayed enhancement, right?
There's
They
some
don't have
capsular retraction. We've
Right, delayed
we've
enhancement.
demarcated fairly well on imaging, but coming back, this question always comes back because of the UK audit study and the French guys saying that even if the radiologist says LIRAD's 5 in the background of cirrhosis, you're still wrong in 10%, and hence the West always biopsies, and ESL guidelines have put it there as far as possible. You must do a biopsy. So even they have put it right in the guidelines.
So is it the non-biopsy is the main reason why the progression in the therapeutics armamentarium of HCC is delayed as compared to the other diseases? So HCC is always labeled as a radiological tumor rather than getting a biopsy done. So in this oncology forum, I would like to ask, is this the main reason why the so much delay?
Not main reason, but one of the reasons. We were never biopsying. When sorafenib came, everybody started jumping onto this gun, and then again 10 years was barren, and now we have collection of so much of molecular data that there was a case I remember where it was classically diagnosed as HCC, heparine glypican positive, but when we did foundation, it had FGFR fusion, so we knew it was not HCC because usually it's not possible. It was all the way cholangio, and they didn't do well on immuno as well. So this is kind of era we are moving with liver masses. So anyways, this was classical cholangiocarcinoma and MSS. PDL1 was negative, IDH1 positive. This patient on day 1 had an NGS, metastatic disease, Bhavin sir. So what we want to discuss, metastatic cholangiocarcinoma, day 1 NGS in your hand, IDH1 positive. You still want to do GemCis immunotherapy, or do we want to entertain GemCis immunotherapy plus ivosidenib?
So currently I do a chemotherapy plus immunotherapy only.
Right.
IDH I usually keep it reserved for as a second line.
Second
treatment.
line. Correct, that's where the approval is.
Yeah, and perhaps I have some confusion whether after chemotherapy along with immunotherapy as a maintenance, whether we can use IDH treatment against IDH.
Correct. So
mutation.
after stopping GemCis,
Yeah.
just continue IO plus ivosidenib.
Yeah,
Right,
that
excellent.
That is
one way we could think. Right. No, he already said he does it sometimes, but what would we do it in India? Chirag sir, what are your thoughts? Would you be tempted, or we want to wait for his study to come?
The Sagar
Because now
trial
the
is
drug
going on.
Yes, but the drug is available in India.
I won't jump in. I mean,
you won't jump in. Okay.
I won't. I will wait for the report. I always do that all the time. So
I know, sir. I know. Correct.
You are asking wrong person. He is a purist. He will always wait. I think I would be tempted to start.
You right, sir. Pinaki and Archit, what about you?
Yeah, I'll also be
because
tempted
we
to.
know now NGS day 1, like Archit you said.
I'll also be tempted because this is a bad disease. So if you have an option, why not to use the best treatment and give both?
In the maintenance phase.
Yeah, in the maintenance.
Alukar sir. Good. Very good. So people are tempted to use IVO in first line maintenance. Very promising for Servier. Yes, sir.
There was a large study. Does a molecular profiling change? It doesn't change that much with chemo. It really changes only with targeted therapy. So we will go with archival specimen for second line setting. But third line, after ivosidenib, maybe we should biopsy. Yeah, I think when you go, right, right. No, actually, you see strange things. Like I've seen maybe 3 or 4 cases now of emergent HER2, like HER2 IHC 3+ positive after prior targeted therapies. So it's right, it's the pressure. Like, with chemo, you're targeting the whole DNA, but with IDH1, you're targeting a specific pathway. So you will see something else emerge. And also, what we look for, again, are targetable mutations. We don't look at the whole microenvironment.
Thank you.
Respond well once you are treated with some targeted therapy before, and then the emergence of new mutation occur. Do they respond as good as if they are detected at the first line?
Well, that's a difficult question. Nobody knows, but like say if an emergent HER2, is it as good a response as before?
Yeah.
Our only real experiences with FGFR2, those emergent mutations respond very well. And in lung cancer, right, you see they do respond. So probably.
Right. And just on that corollary, so sir, me and sir were discussing the same, that can we induce the mutations in our patients like Maya trial did for colorectal, when we do temozolomide, make them hypermutated and then give them IO, seems to kind of work or not. So what I learnt in oncology is that cheating your way to develop a mutation and then targeting, it's probably not the smart way to deal with malignancy. What are your thoughts on that? Developing FGFR mutation on the suppression of pemigatinib, it's a separate story. But inducing a patient who never was FGFR and getting some alteration and then targeting. That's right. That's right. 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 And then they. Right. No, so let's say it develops PIK3 on top of it.
Yes.
And then you target PIK3. In colorectal, it has not shown, impressive responses. Right. Okay, last 5 minutes.
Before we move on, I think I want to answer from Professor Javle in your question of a Safir like a situation. Outside clinical trial, if the patient has IDH1 positive or FGFR positive, will you give maintenance TKI along with immunotherapy after GEMSIS?
I think so really I must have oversold this maintenance thing, so it's not standard of care anyway. But for FGFR, I'm less tempted because they respond so well, So if they progress down the road, you can still use FGFR. I think for like PARP, we use that in pancreas cancer, right, for the POLO trial. I think ivosidenib is in that territory. But I don't want to leave you with the impression that this is the standard of care by any means. I think for those cytostatic drugs,
right.
This is an option.
Right. So it's a static drug, so hence maintenance is probably where it would be. While FGFRs are more potent, you have robust tumor shrinkages. This is again one intrahepatic cholangio, and we got this because I knew sir was going to come. Hitesh sir. This case was deemed, this was asked to 5 different surgical oncologists, and there were discordant views. So what would you do in this? It's limited to the left lobe. Biopsy proven cholangio. CA19-9, 1800. 64 fit patient.
So this patient has left lobe with intrahepatic cholangio,
right,
with left portalomein involvement, and doesn't seem to have much nodes. So after doing the metastatic workup, this patient will qualify for resection, left hepatectomy.
Right.
So if you see the left portal vein is involved.
Right.
Volume seems okay, liver is not cirrhotic, spleen is okay, and there are no periportal nodes. The nodes which are there
Tiny.
will be there anyway in the resection margin. So if you can see the left portal vein is involved, so it's blocked. But there is no significant hypertrophy on the right side, but still this seems resectable. So I will, as you have said, the biopsy is done.
Cholangio.
Yeah, so we'll do a PET CT or a HRCT to rule out any mats
Thorax.
and then resect it.
Right. Okay. Any here, why no neoadjuvant in this case versus in gallbladder?
Gallbladder is more aggressive than this, and secondly, this is anyway resectable, and chemo may not be that sensitive to downstage this, and surgery seems is very safe, and then you can later on give something as an adjuvant.
Any
rather than
last
upfront.
comments on transplant in cholangio?
I don't think so, and especially in such cases, it's already portal vein thrombosis, a tumor thrombus.
If no tumor thrombus,
then also cholangio very likely to recur. So we don't transplant, and there are centers who does it, but they are downstaged and then transplant, but still a high recurrence compared to HCC.
Does Dr. Divakar transplant cholangio?
No, I don't think.
Any, sir, in MD Anderson, do these patients ever get transplant, cholangios?
So we have a protocol. So actually, as you know, Hyler is approved, right, in many places,
Right.
the Mayo protocol. We have a protocol for intrahepatic cholangio. Because you're absolutely right, the results were initially disappointing, so most people think as an exclusion, right, intrahepatic cholangio.
Right.
But the problem was that these people, most of them were de novo, like people who were newly diagnosed and then immediate transplant. So we have a protocol where patients have to have at least 6 months of disease stability, and of course the usual no extrahepatic, etc. So by the time they get a transplant, it often ends up being several months more. So if you have liver limited disease for 8 months, 10 months. So yeah, we have a protocol, we have treated probably 60, 70.
Oh.
And they have reached that 50% 5-year benchmark. So we are allowed to continue. We want to get about, it's really a transplant run program, but I was one of the people who pushed them to try.
Right.
Maybe on the waiting list compared with the other patients. So they are not, they are extended criteria. So patients who have fatty liver or something,
They get marginal organs.
marginal organs or living donor transplantation. So yeah, we had published a few series now. And I think honestly, they do better than Perihyla.
Correct.
Yeah.
And sir, TIVs in the intrahepatic cholangio still transplantable?
Which one?
Tumor in vein. Like HCC classical, it is said that VP4, VP3 are non-transplant.
Yeah, right. No, we would, I think that would be a surgical decision. You're right. I mean, that degree of thrombosis.
No, but I asked the question that even if there was no thrombosis in India, I think so cholangio is usually said, isko nahi karenge. So, and we have now good transplant, like sir is doing transplant for more than 2 decades here. We have a transplant unit. When we discuss cholangio, it's usually last on their list. So like I heard you once say that make a protocol and then stick to it, rather than chasing any clinical trial. If you have an MDT and if you are making a institutional protocol, just stick to it and just mention that these cases we will do, this we will not do.
So, Viraj, transplant is difficult, right? They're limited organs, so you can't experiment too much. But you have, this was based on data which showed that liver-limited disease has a median survival of, I think, 15 or 18 months in intrahepatic cholangio as against the regular metastatic, which is like 10 months. So we started doing it in a very measured way. You're aware of the Barcelona data with cirrhosis and small intrahepatic cholangio. So that is approved now for us. Small, less than 3 centimeters, but we now do it for others.
Right. So in India, anyways, majority goes for living
live
donor.
So in India, we have
a lot of
majority
livers.
live donor program.
We have
so
a lot of livers.
They are not competing with cadaver. So if they have a donor, then maybe right, you with a strict protocol.
Yeah, I think you have to study your patients.
Yeah.
I mean, I can certainly send you our papers, but you have to study your patients and see
If
how
aggressive the
it works. Because I think, for instance, certainly HCC, but intrahepatic for in our series have done better than perihilar. Perihilers do very well in Mayo because half of them don't even have cholangio. They're PSC.
Yeah. So again, this was a case from Dr. Shraddha Patkar from Tata. So in this case, they underwent GEMSIS, neoadjuvant, and after neoadjuvant, the response scan showed kind of progression of the disease. So what they did is added radiotherapy in form of SBRT and then moved to second line Capiri plus Durvalumab, treating like metastatic disease. And after 4 cycles of immunotherapy and irinotecan based therapy and SBRT, patients now got a response. So there was necrosis seen on the imaging, and the surgeons felt tempted, and they went in, and I don't know this is all red for me, and
They have implanted the middle hepatic vein to the IVC.
Right.
It's a jump graft. So they preserved middle hepatic vein.
Right. So,
distally.
and all I can see is this came out as PAT-CR. These are, of course, these anecdotes, how, and this, of course, brings the question that there is a study of immunotherapy being used as a neoadjuvant downstaging pathway. We don't use that here. Sir, any experience of using, is Dr. Shroff leading any trial on immunotherapy for downstaging for our surgeons?
I mean, like GEMSIS over.
Kind of.
Yeah, that's what we do. We have
As a trial.
As a trial, yeah, two therapy both, but as a trial. And we found actually for patients that are immunotherapy and immunity don't have devastation, they have a better survival.
Right. Correct.
And that's true in breast and many other diseases.
Right.
So I think there's room for immunotherapy.
So Chirag sir, it's not approved in NCCN. What should we do here?
So, as Dr. Talati just said that I'm a purist.
I know, so I'll ask
from,
you.
from
You are teacher for all of us, sir.
No, what I'm trying to say is that from the trial that is ongoing anywhere, I mean, I need, rather we need at least one interim analysis showing some sort of improvement to adapt in the standard clinical practice.
Right.
So there was, at ESMO, there was this trial,
It's
phase 3 trial, right? Suggested the China combination, GEM, OX, and tislelizumab and lenvatinib, because they call it GOL. And they had a phase 3 trial, compared that neoadjuvant versus surgery followed by Xeloda. So the primary endpoint was event-free survival, and it was a positive trial, so it was presented at ESMO.
Okay.
And published in Lancet.
Right, the teslelizumab. So that's reasonable for us to consider in patients which are borderline, surgeons thinking both ways. I have tried in one patient, so but that's anecdote. Right. I think so. That's about it. If anybody has any questions, or else I'll hand back to Dr. Sana and Servier. Thank you once again.
Thank you so much, Dr. Viraj sir, for discussing all the cases. Any last word from Dr. Chirag sir or Dr. Talati sir? Final comments.
Right, I think, thank you, Servier, for bringing such an excellent program for today evening, and bringing Dr. Javle, especially for the great interaction and learning. Thank you, Viraj and Chirag, for excellent discussions.